we are on left with the 3 people to start. Now maybe I can use the 1 or so minute when the 3 people come on, just to really share our feelings for you people. It is quite sad that you people, the learning has really been distorted a lot due to these lockdowns. We hope sincerely that you will pick the interest and courage to continue learning the concepts which we have introduced to you. We also hope that some of you will pick the interest in future, to pursue specializations in the field of, let's say, oral maxillofacial surgery. It is open to you, and so so that you can build on what you have learned. And we also hope that you keep reading, you keep watching YouTube videos about procedures, about, learning more, so that when you finally become interns, when you finally become medical officers, you are able to continue, applying the principles. Yeah, okay. That said, I can see that some people are dropping off, and now I'm going to mute. I'm going to put off my video, and I'm going to go straight into the class, because I see that we may not actually raise the numbers as I hoped. So, are you able to see the slide?
Yes,
Yes, doctor.
Okay. So today we are going to learn about tooth extractions. Really not any details, but just again an introduction, if I can say, because to learn the details of this, we'll need, first of all, to spend, some good number of days learning again all the detailed science of everything you do, from the anatomy once again to the clinical processes and procedures and so, and the instrumentation. So now we only barely have 1 hour, because now you guys have to go and read. So in 1 hour also, how much can we do? We can barely do much, and we are just going to go through the basic highlights so that once again you appreciate what it means. So okay, so the objectives, 4 core objectives. I hope by the end of this session, those of you who are present, who will have finished all the minutes with me, should be able to define exodontia, should be able to state why we do it, should be able to explain some of the basic steps. You need to be able to tell your patient what are some of the potential complications. So, by definition, exodontia or tooth extraction is the painless removal of a whole tooth or tooth root with the minimal trauma to the investing tissues, so that the bone heals uneventfully and no postoperative prosthetic problem is created. Yeah. There are some key concepts here. For example, the whole tooth. That means if it is an anterior, the whole of it its crown plus its roots are out. If it's a posterior, the crown and all the roots are out. You know, some of the posterior molars have 3 roots, others have 2 roots. I think you guys already know that very well. And so all those come out very clean. Then the next set of concepts is minimal trauma. Minimal trauma means you have not damaged the gingiva, you have not done excessive damage to the alveolar crest, yeah? You have not fractured a mandible, you have not fractured a maxilla, yeah? So that is what minimal trauma means. So with all that, you are also, and of course, you know, for things to be uneventful, that means you have observed all the surgical, you know, protocols. You have minimized infection control, everything. So that is what it means. So when did the tooth extractions or exodontia start? Some brief history. The history claims, of course, I was not there those days, that in the 7th century BC, extractions were being carried out. And the evidence for this is the carvings or drawings of forceps on the walls of Egyptian caves. Okay, so you know, 7th century BC is almost maybe it's now almost 9,000 years ago. Yeah, that's about almost 7,000 years before Jesus the Christ was born. That is how early it was. Then in the 5th century BC, Hippocrates, you know, the one in whose name you will swear to become doctors, also made a mention of dental forceps. He talked about dental forceps. Yeah, that was in Greece. Those forceps were made of iron and were called odontagra. You know, Greece, the Greek language, odontagra. And later in the 14th century, still, Guy de Caulebec invented what they call pelicans for dental extraction. They were named after the bird, you know, pelicans. Yeah. So because the beak of those forceps were resembling the one of the pelican. In the 16th century, that is now recently, after Jesus the Christ was born, Pierre Foucault, who is acclaimed as the father of modern dentistry, modified the pelican with the proper dimensions. Because you see, tooth extraction needs a lot of science. It is not as simple as it looks. So to create forceps which were functional, which would do the right job in the right hands. So that is what this guy did, okay? And also he described the operator's position, the surgeon. In what position should the surgeon best stand to remove which tooth? Is it an anterior upper, anterior lower, posteriors? Is it a posterior upper, posterior lower? Because each of those actually has got its own position. So he described that. In the 18th century, the dental key, also known as clef, the Garrett got was also invented because it was modeled after, you know, the keys for a door. Yeah. Then in recent times now, the modern day forceps were introduced by Sir John Toms. Okay. Yeah. So that is it is source for you that the practice of dental extraction has spanned millennia. Yeah, it has spanned millennia. So we already know from lectures with Dr. Pizra that dentition is in both maxilla and the mandible. Okay, maxilla and mandible. The maxilla, of course, is a paired bone forming the midface of a person, bearing upper teeth, separating the oral cavity from the nasal cavity and maxillary sinuses. Compared to the mandible, it is composed of spongier bone with thin cortical. Palatal processes extend from both the maxillary bone and meet in the midline to form the roof of the oral cavity. I think I already talked to you about the palate last week, and I even sought for some defects which can happen in the palate, the cleft palate. And so now you know that the palate has two sets of bones, one from the right, one from the left, and they meet in the midline. Okay, so this is how the teeth are inserted: the anteriors, the central anteriors, laterals, the canine, the premolars, molars, yeah, the last molar here. You can see these molars. Now it has this root, yeah, and the two lateral roots, medial, and the laterals are usually two. The medial is one, yeah. So yeah, here you can see clearly the spaces 1, 2, 3. That is how the maxillary molar roots will look like. Yeah. So these all have implication for the procedures you perform. Yeah. So you can see here is the last molar. Usually the roots tend to fuse. Most times, most times the roots tend to be a bit fused. There are 3, but they are always stuck together. And this process, the maxillary tuberosity, you can see is quite a fragile bone. So we shall also have a mention of what sometimes can happen to this maxillary tuberosity. Because of its inherent anatomical features, the maxillary teeth tend to be a little bit easier to remove. And some of the reasons are that the maxilla is characterized by thin cortical plates with the spongier bone, due to which the alveolar sockets expand easily on the application of pressure, facilitating the extraction process. 2, due to thin cortical plates, mere paraperiosteal infiltration of local anesthetic. We talked about earlier in the beginning of my classes. So when you infiltrate LA around those teeth, then you are able to achieve adequate anesthesia. Then third, maxilla has better vascularity compared to mandible, and hence healing is always faster in the maxilla. However, because of, again, of its own nature, there can be some complications while dealing with maxillary teeth specifically. Okay, 1, use of heavy elevators. Elevators, you remember this word elevators. I'm going to show for you how elevators look like. Is associated with the risk of fracture of the alveolar bone. So you have to be careful in using those elevators. 2, the root apices of maxillary molars are in close proximity to the floor of maxillary sinus. Okay, the maxillary antron. I think in ENT you guys have learned that. So now today you need to again remember that the roots of the maxillary molars are they are so close to the maxillary antrum. Yeah. So, as such, during extraction, sometimes we experience what they call oral antral communication, a fistula. Yeah. Because you remove the tooth, then the apex comes with the thin bone at the floor of the maxilla, of the antrum. Yeah, the antral floor, it is pulled out with the apex of the root, and as such, creating a communication between the antrum and the oral cavity. So that is quite nasty. Yeah. There can also be spread of periapical infection into the sinus. Yeah, it is just simple. If there's an infection in the pulp, which goes into the apex, then it will go into the sinus. Okay. Then there can be displacement of the root into maxillary sinus. So, because sometimes the root fractures, and then somebody is using an elevator and not using it very well, and it exerts pressure on that remaining portion of the root, then it will simply just slide into the antrum. Yeah, so these are some of the things which happen. Somebody may come and say, I went to the dentist, they removed my teeth. And now when I blow, I feel it in my mouth. Yeah. So when I blow my nose, I feel things going into my mouth. So that is just simple. Then you will already know, wow, there is oral antral fistula. Yeah. Now, in case somebody really is having a very bad tooth, and then has severe sinusitis, then where is the abscess coming from? From that bad tooth. Yeah, all of you guys know that very well. Then another one will tell you, I went for an extraction, now I'm having problems. So the root has gone inside. Yeah, so I think those are practical things which you guys have to be aware of. So thirdly, the maxillary third molar is present in the tuberosity, as I already pointed out for you. Therefore, there are high chances of maxillary tuberosity fracture in patients with unfavorable and bizarre root patterns. Okay, yeah, and also in the elderly, because the bone is now even more spongy. Yeah, so you are trying to remove the tooth, then it will come with the tuberosity. Then what about the mandible? So the mandible, again, just a reminder, because I know you guys know this very well, is the horseshoe-shaped, mobile, and the heaviest bone of the craniofacial scalp. Compared to maxilla, it has less spongy bone as well as vascularity, and it has thick cortices. Yeah, it has thick cortical bones. So again, here is your mandible, which you know very well, very, very well now. And you see the sockets, yeah, which are in place. Then you can see some more. Of course, there are these remaining teeth, yeah. And these molars, yeah, they are quite beautiful molars. The last one, yeah, the middle and the first molar. This is the first molar. And you know it always erupts in guys when they're about 6 years. And so you can see the typical arrangement of roots of this of these molars. Molars have of mandible, usually they have two roots. One is meso, one is distal. So yeah, and you can see they have one canal, okay, canal, yeah, this is the root, the meso, the distal, yeah. So, yeah, basically, you know this very well, and you can see what we are talking about. The cortical bones here are quite robust, yeah, robust, quite heavy as compared to the one in the maxilla. So, what are the things which complicate extractions in mandibles? So, the things which make extractions within the mandible are one, presence of the thick cortical plates. So when you are a weakling, of course, really the whole thing is about technique. But I mean, you still also need some bit of energy to perform the procedures. Yes, so it's a little bit more difficult compared to removing a tooth in the maxilla. Then two, due to the less vascularity, healing is slower, yeah, as compared to the maxilla. Then the mandible is depressed when the mouth is open. Hence, there are high chances of temporomandibular joint injury or dislocation. Now, last time I told you guys to go and look for the video to see how you can reduce a dislocated mandible. I hope you guys have done that. Yeah, because somebody who is inexperienced, you know, we have many parts. We may attempt to remove a tooth in the village and ends up displacing a person's jaws, and the nearest clinician is only you. So you must know how to reduce those dislocated mandibles. Okay, a word or two about the teeth themselves. I don't have to emphasize this, but you guys already know, but I'm just specifically highlighting issues relevant for extraction. So the shape of crown and roots must be assessed carefully. Preoperatively, is my crown still intact? Is it fractured? Is it grossly decayed? Those are some of the questions which will be going through the operator's mind. Okay. A narrow tapering crown requires the use of a lighter beaked forceps, whereas a bulbous crown needs to be extracted using a heavy beaked forceps. I'm going to show for you examples of forceps. If the tooth is multi-rooted, which I've already showed for you the examples, the molars, it offers more resistance than a single-rooted tooth and cannot be extracted using a rotational force. You cannot use a rotational force. Yeah, those single-rooted teeth, like the anteriors, you just simply fix your forceps down and hold it very well and rotate. And you just dismember those periodontal ligaments and you are able to pull it up. Yeah, but that's not the case with those multi-rooted teeth. You attempt to do that, you are going to leave all the roots down there, and then that will be another story. Now, when the roots are divergent, like those maxillary molars, they are very good. I've already shown for you an example how the roots can actually be divergent because you have those lateral roots and then the medial root. Yeah. So the application of heavy forceps will lead to root fracture. So you don't want to apply excessive pressure on those roots, otherwise they will fracture. Then there are dilacerated roots. These are prone to fracture. So those roots, the dilacerated roots, they are like they bend at the tip. So they are not normal. They are actually bent at the tip. They are not divergent. The divergent roots are normal, they're straight. But a dilacerated root is like something, it's as if it had been traumatized. Then at the apical area, it is bent. It can sometimes almost be bent like 90 degrees. So it is just not possible to remove such a root. And the bend can be in any direction, so that is the issue. Now, careful approach is required while extracting non-vital and odontologically treated teeth. Yeah, non-vital teeth are very difficult to extract. Yeah, extremely, they are fragile, they're very fragile, they are brittle. Yeah. So we said we are also going to learn why do we do extractions. So extraction of the teeth can be either prophylactic or therapeutic. So two basic reasons. So these are some of the indications. We are going to go through them. There are about 10 indications why we do extractions. Number one, this you already know very well. Dental caries, which is very common. So in case of dental caries, which is extensive, where the crown can no longer be restored, then that is it. You've got to extract. Or it is, well, there's the pulp pathology, there's necrosis and abscess, and you can't treat with endodontics, then you've got to remove it. Severe periodontal disease, and the tooth is highly mobile, no time to waste. You've got to remove it out. Periapical pathology, whereby you've got to prevent infection, and also, and maybe restorative approaches for periapical procedures have failed, we've got to remove. Then orthodontic reasons, there are about 3 orthodontic reasons. Malpositioned teeth, when the teeth are malposed. In this case, the teeth are mal-aligned or misaligned and cannot be reoriented within the proper arch formed with orthodontic treatment. So there's no option. Then you want to create space, to gain space to align malposed teeth. Then in that cases, you have got to remove some. And in many cases, they are the premolars who are sacrificed. Then sometimes there's what we call serial extractions. This is when there's what we call mixed dentition. Mixed dentition is when you have both deciduous and permanent teeth. Like from 6 years, 7 years, 8 years, up to almost 12 years. So so there you get mixed dentition. Pre-prosthetic extractions, sometimes you want to do a prosthesis, so you want to do prosthetic extractions. Like you are going to do complete dentures or even partial dentures, you sometimes go to remove the remaining teeth. Fractured teeth, the tooth is fractured and there's no way you can conserve it. The fracture is in such a way that it is just, we usually classify fracture of teeth. So there are certain levels where it is just not possible. For example, a fracture which goes through the pulp, that tooth has got to be sacrificed. There's no way you are going to restore it. Then root fragments, when it's only roots remaining, you've got to remove them. Then there's what we call supernumerary teeth. Supernumerary teeth means just many teeth. Sometimes you can find that the person has more than the normal number of teeth. So those are the extra teeth, you have got to remove them. Then sometimes there's a retained deciduous teeth. The person fails to set off all the deciduous teeth. So, and their estate cannot look good. You got to remove them. Then impacted teeth. These are mainly the teeth which are fond of getting impacted. You have the canines, you have those last molars. The last molars are very notorious and canines. So those, they will not come out. So you have to remove them. Yeah, but we usually remove them. So then a tooth or teeth in fracture lines. Yeah, when I think we talked about oral facial fractures last time. So a tooth in a fracture line which may not survive, you are better off removing it, or which may act as a source of infection, you are better off removing it. Then teeth are associated with pathologies. This, for example, a tooth inserted in a cyst, or any other tumor, or osteomyelitis, or neoplasms. Yeah, those will come out. Then teeth in the fine line of radiations, when they are going to do radiation, those routinely in the olden days had to be removed because of excessive radiation. Excessive radiation caused vascular problems, yeah, and osteoradionecrosis. Yeah, because there will be less vascularity now, and as such, get osteoradionecrosis, which was almost always problematic. So, what are some of the reasons why we may not remove teeth? There can be systemic or local. So, what are some of the systemic reasons why we may not remove? One, neurological disorders like stroke and epilepsy. Yeah, stroke, epilepsy, you have to take caution. Pulmonary disorders like bronchial asthma, TB, chronic obstructive pulmonary disease, and pulmonary effusion. Then cardiovascular disorders like hypertension, uncontrolled hypertension can be problematic. Then cardiomyopathy, valvular disorders, ischemic heart disease, chronic cardiac failure. So you guys are very familiar with these conditions. So you should even study more why we may have to be very careful attempting to do extractions with these kind of conditions. Hepatic disorders like acute liver infections and liver cirrhosis. Yeah. Yeah. You know, when you have those conditions, a person can even be prone to heart infections. They can even have maybe bleeding disorders and so on and so on. So you have got to be careful. Then renal disorders like glomerulonephritis, uremia, chronic renal failure. Yeah, you've got to be very, very careful. Then metabolic disorders like diabetes, yeah, DM, because DM, uncontrolled DM is likely going to compromise bone healing and tissue healing. So you don't want to expose tissue to trauma when it may even refuse to heal. Yeah, so, and all these other conditions. Then hematologic disorders, severe anemia, leukopenia, thrombocytopenia, and so on. Yeah, and anticoagulants, bleeding and clotting disorders. I think we already talked about this. So you must be careful. This can be done in highly specialized settings, but not in the ordinary dental clinic. Otherwise, you are going to open a Pandora's box, which you may not be able to handle. Patients who are completely immunocompromised, it is not advisable to do extractions in them because, again, they may be getting other secondary infections and failure to heal. Yeah, so you know the immune system is already compromised. That was systemic. Now, locally, what could be some of the reasons why we may not want to extract? Yeah. When the tooth is in a malignant growth, yes, you have got to be careful because you are going to be spreading that tumor. So you must minimize. Then a tooth associated with vascular lesions, because you are going to create a bleeding which may not be easily controllable. Then a tooth in close proximity to vital structures. Also, you want to avoid that to prevent damage to those structures. Then tooth in an irradiated jaw, you want to avoid it because the healing will be compromised. Tooth with an acute infection, yeah, sometimes it's also very risky. You want to first control that infection. So, those said, and then we are going to look at the instruments, the armamentarium. Now here, these are forceps. You can see that these are different types of forceps. Now, when you see forceps like these ones, 1, 2, 3, 4, and another one is this one and this one. These forceps are used for the lower teeth. Yeah. Now, a forceps which has a very narrow tip like this, these are the ones which are which can be used for the anterior. Yeah, they can be used for the anterior. Also, sometimes they can be used as root forceps. Then these ones can be used like premolars. Yeah, and this one, ultimately, this is a molar. This one, you know, it has a wide curvature here, and it's very robust. Yeah, it usually has a beak here and here, which inserts in between. The beak, as you know, is a sub-beak here, and on this side, that's what inserts in between those two roots, so that you can hold it firmly and to be able to move that tooth out. Now, on the other hand, forceps like this one, this one, this one, and this one are for the upper teeth. Now you can already see that this is an anterior, this can be a premolar, then these are molars. Yeah. Now the molars for the uppers are not the same. The one which is for the this one here is for the right, yeah, upper molar. Then the one for the left upper molar, this beak will be on that side. Yeah, it will be on that side. Yeah, but this one, the beak is on this side, so you can see it's for the right upper molars. Then the elevators, which we said cannot be used by people who are not trained. These are the elevators. Because first of all, if you are not trained how to use an elevator, you are going to pierce yourself very badly because they are very sharp and it can cause massive damage. Yeah, you can see this is not even to scale. Yeah, they are slightly bigger than this. Yeah, so if you can get injured by such a thing, it will be massive trauma. Yeah, so now if you don't injure yourself, you are going to injure the person very badly. So it needs when you are really trained. Yeah, if you are not trained, you are better off not using an elevator. You rather use a forceps. A forceps you may get away with it, but this one you may end up causing the kind of trauma which you don't like. Yeah, so this is a straight elevator, and also this is one. This is a straight one, but for the roots. Then these are pliers, and this is a root forceps. Yeah. So this is, I mean, elevators, root elevators. Now they think about this type of elevators, the ones which are bent at the tip. They are usually right and left. They usually come in pairs. There's one which is bending towards the right, and there's one which is bending towards the left. And for a reason, because sometimes you want to raise the tooth from the distal end, or you want to raise it from the mesial end. So that's how these things are designed like this, these tips. So now this one is for use from the mesial end, yeah. And this is for use from the distal end, the way they are pointing. But this is for, yeah, in particular, if you are now like, you are removing a tooth in the lower right, yeah, lower right. This is going to remove from this, you are going to place this in the mesial end, then this is going to be in the distal end. Yeah. So, yeah. But if you are again removing a molar from on the left side, now this is going to be in the mesial side, that's going to be in the distal side. So it's going to change like that depending on which molar you are going to be, or which side you are working on. But these ones are just universal, these ones. Yeah, these straight ones, they have no code. These apex elevators, yeah, they're also similar to this one. Yeah, they have sides which they adopt. And then there are other types. We have others which are called T elevators. They have a T handle. They are not like this. They come a little bit straight here, and then they form a T at the tip. Yeah. Oh, okay. I'm going to stop the presentation here a little bit. Then I want to just ask to watch a small video of about 10 minutes, which shows for us how this stuff in real practice works. Where is my video? Yeah, the video is here. I'm gonna cite it right way.
Doctor, there is no sound.
Oh, there's no sound.
No.
Now if there's no sound, okay, let me remove my whatever.
Psychological assessment and the radiographic analysis of the tooth, you're now ready to sit down for a few minutes and mentally extract the tooth. Now, nobody ever taught me this when I started taking teeth out, and I wish that they would have. Now, it seems trivial, but if you can live all the surprises in your mind prior to taking that tooth out, there will fail to be any surprises. So what I mean is you sit down, you take all that information that you've gathered from those first 3 assessments that we've done, and we start going through the scenarios. So we're going to say, okay, we'll start non-surgically, for example. We're going to try our elevator, and we're going to try our forceps. So you determine, can we do that? And if we do that, where's our elevator most likely going to be on that tooth to have the best chance of success? If that tooth is going to break, where's the weakest point? Where is it likely to fracture if I put a forceps on it? If that happens, what instruments do I need? You need to have these in the operatory. Don't have them open necessarily, but you have them right there in case you need them. At what point do you pick up a handpiece? Know this in your mind. Have it ready to go before you do the extraction. You should have, I would say, at least 3 scenarios for every tooth you take out, no matter how simple it looks. So complications can happen with even the most easy-looking extractions, and if you're ready for them, it's no big deal. We're going to use this tooth here as an example for extraction planning. So we're going to talk about how you might progress through a tooth if things don't go as planned. So we're going to have a scenario A, scenario B, and scenario C. So scenario A is you look at this tooth, and let's say that you don't have a lot of experience. So Now you're going to look at it, you're going to think, okay, well, maybe we'll try our elevator on here in our forceps, which is what we normally do with the tooth. So we're going to apply our elevator onto that mesial buccal aspect of the tooth because the distal is all decayed. So what you do is you start to elevate on that tooth and you're not getting a lot of movement. So again, rookie mistake, you're going to grab your forceps and you're going to try to force that tooth to move. Now when you do that, the crown snaps off. So our crown is gone. Now, if you haven't prepared ahead of time, this is a scary situation. But we're now going to move on to scenario B, which we've already planned in our minds, and we know exactly what we're going to do next. Anytime that a tooth breaks on you, take a minute, stop, and reestablish good visibility, good light, and good access. Those are your 3 surgical principles. Take a minute to do it. Sometimes when you get working at a tooth, you get focused on it, maybe your assistant's getting focused in, nobody's moving the overhead light, or retraction is getting a little poorer as you're going. Get everything optimal. Get in there and irrigate that site with sterile saline and suction it out really well. If any tissue or tooth fragments are obscuring your view of what's left there, remove them with the hemostat and get everything very, very clean and very clear so you can distinguish what is tooth and what is bone. Now, as you get better at extractions, at this point, you're not going to be sweating like you would be when you first start out. So usually if you break a tooth when you first start, your heart rate goes up, you perspire a little bit, and you're starting to have doubts about whether or not you're going to get this tooth out. As you get going with extractions and you get better at this, now you go, oh, that was inconvenient, but guess we're halfway done. So it gets better, trust me. Now, when you look down at this tooth in particular, the nice part about it is you've got gutta perca there. So you've got basically 3 points of gutta perca that you'll see that are showing where those roots are located. Now, this is really handy for sectioning. So we're going to pick up our handpiece next, and we're going to cut between those roots. So when we're dividing the roots, what we need to know is we need to stay clear of that lingual mandible. But other than that, our critical anatomy is pretty far away. So we're pretty much in the clear when we're sectioning this particular tooth. So we section this tooth, we then use our instrument of choice. So mine would be the EL3SX luxator. I put it in down next to that mesial root, and I start to work at that a little bit. And we're going to loosen it up and push it in to where we've sectioned that tooth and remove some structure to be able to get some clearance for the root to come out. So that root comes out quite nicely. And what we do then is we're going to take our elevator and we're going to now work it between the distal and the third root. So we're going to work it in against the accessory root to get things moving in either direction. So we're using the other root that's available there as leverage to get some motion on that third root. We then go and we deliver the distal root using either your spade elevator or your elevating luxator, whatever you like to use. You get that tooth out. And now you go and you try to get that third root out. You manage to loosen it, and manage to luxate it a bit with that instrument you're using, but it's still pretty firmly bound in there, and we're having troubles getting it to move. So our initial approach of our luxator, for example, isn't working. What do we do next? We're having some difficulty establishing a purchase point on this third root, or this accessory root. Part of it is that we're not used to dealing with these. The other part is that there's just bone all the way around there, so it's broken off basically flush with the bone, and we can't get an instrument in there. Our option now is to remove some more bone using either a handpiece or an instrument. So you could use a cryer elevator to basically get in there, scoop some bone away from the inner radicular region, and then get that root out with that wheel and axle motion. We'll talk about that in another video. Or you can pick up your handpiece and you can artificially create a purchase point. So what you're doing with that is you're using a 699 or a 700 surgical length burr in your surgical handpiece, and you're creating a trough around that root structure at the expense of the tooth more than the bone. Now what you're doing is you're creating space for the instrument, so you're creating a purchase point, and you're also removing any bony obstructions or anything that might be anchoring that root in place, preventing it from coming out. So once you do that, you make that little trough, you can then place an instrument and get a good purchase in there, and you're going to lever that tooth out or luxate it out so that the root pops out from the socket. When we're finished with that, anytime we've got an extraction like this, where we've broken the tooth, we've been cutting bone or breaking bits of bone, you need to get in there with a curette. You need to get to the base of that apex, and you need to go all the way up the walls on all sides of that socket, get all those little bits and pieces out. Use your small suction to get down in there, irrigate it well with sterile saline, and then basically have the patient bite some wet gauze and hold hold it in there for 20 minutes, change it as necessary, and you've just successfully removed a tooth that looked like it was going to be a really tough one. And the reason you could do it is that you had your extraction plan ahead of time, you had your instruments available, and when things happened, you knew exactly how to respond, and you did it efficiently.
Okay, let me go back to our class. Yes, so yeah, he was illustrating for you some of the techniques which can be used for removing a tooth, and also the cautions to be taken when you are going to be removing a tooth, because a tooth may appear to be very simple. You will say, ah, this one is easy, I can do it. But then without proper preparation, you may end up creating complications. So good. So what are then some of the complications broadly when you do extractions? One, there can be general complications. This can be postoperative pain or postoperative hemorrhage. Then two, the tooth, with problems with the tooth itself, which can be like the root fracture, root displacement, which I already talked about, into the antrum, then a loss of tooth into the pharynx. Yeah, this happens. Then three, injury to adjacent teeth. You don't want to injure the adjacent teeth, because then that is really a lifelong complication. So that injury can be fracture or dislodgement, luxation, then sometimes some person is not careful, like the way you can cut a wrong leg. One time it happened here across in Tanzania. You can also do a wrong extraction. Four, injury to the soft tissue, abrasion, puncture, tear of the mucosal flaps. The mucosal flaps tend to be common because you have used the forceps wrongly. It cuts the gingiva, then you are pulling, and that means the gingiva is somehow still attached to the tooth, and then you end up tearing. Yeah. Then injury to osseous structure, fracture of the alveolar process, which is common, fracture of maxillary tuberosity, which is common, injury to adjacent structures, injury to regional nerves, injury to regional vessels, injury to temporomandibular joint. We talked about this. Then 7, the oral-antral communication and fistula, which can be really a very serious complication. Then fracture of the mandible, yeah, I've seen this happen before. It can be nasty. Then number 9, delayed healing and infection. So you have, of course, infection itself, there, wound dehiscence. Yeah, sometimes you do surgical procedure, then there's wound dehiscence. Yeah, because of all sorts of other reasons, which maybe we may not discuss here. But I think you guys already know the broadly reasons for wound dehiscence. Yeah, you know that. So you just transfer some of those reasons here. Then dry socket, or what we call alveolar osteitis. Yeah, I'm going to mention a little bit more about that, because that's a very, very common complication. Then osteomyelitis, yeah, osteomyelitis. Then there can be other uncommon complications which are not listed here. Things like Ludwig's angina, complications like abscess going into the thoracic cavity, you know, things like that. All sorts of complications can always happen. Yeah. Then in modalities to manage hemorrhage, pressure packing, because after extraction, you are definitely going to expect some bleeding, so you do pressure packing. If it is not responding, if bleeding is continuing, injection of local anesthetic with the vasoconstrictor, we already discussed that long time ago. Then sometimes because you have done traumatic extraction, then you go to do curettage. You have to clean the debris, otherwise they will act as bleeding spots. Then doing suturing, then sometimes use of resorbable cellulose, like such. Then mechanical obstruction using bone wax, yes. Then if it's in some of the parts, then you can sometimes use coagulation if it's necessary, or you may want to just simply tie off the main source of that blood vessel. Then, I said I was going to mention a little bit about alveolar osteitis, which is called also dry socket. Dry socket means delayed healing with moderate to severe pain. This guy called Barnes hypothesized that that it is due to trauma and inflammation, which causes the release of stable tissue activator from adjacent bony socket and soft tissue. So in essence, dry socket usually happens. The commonest observation we have seen is the fact that a tooth is extracted, but many times it's traumatically done, and then the clot fails after a day or so. When the clot fails, then it leaves an empty socket, which is not supposed to be. So when the socket becomes empty, then an empty socket will get infected. Okay, there are some questions, but I will answer them after I'm about to finish the presentation, so I will answer that question. So the socket becomes empty, it gets infected, and really can be very painful. So that is in a nutshell what happens. So according to Barnes, the hypothesis, tissue activator converts plasminogen to plasmin, which causes lysis of blood clot and pain. Management of dry socket involves the relief of pain and ameliorating healing. A loose dressing composed of zinc oxide and oil of cloves. We rarely use cotton wool, but we use gauze. You apply the zinc oxide mixed with the oil. Is the common one in practice we have is called eugenol. You mix that zinc oxide with the eugenol. Then you apply it on the gauze, and then you pack the socket with it. But first you need to curate, irrigate, and reactivate some bit of bleeding, and allow it to heal. Then, of course, you can give them painkillers and so on, and sometimes some antibiotics. Okay, so that said and done. Now let me now see the question. So the question was, when tooth has been normal, but fractures in accident or fight. Yes, when people fight, they can fracture their teeth. But it's still in the socket. How do you manage it? Yes, again, we have to classify the fracture. We have to classify the fracture. If, for example, if the crown is completely gone, then that tooth still has no use, so it has to be removed, and then you replace it. You can replace it with a denture, you can replace it with a bridge, you can replace it with an implant, but that one will have no use. But in case if the fracture is on the enamel and it's not involving the pulp, or it is, if it's not involving the pulp, or if the enamel is the one which has just crushed, and maybe it's at level 1. So there we can just restore that. Maybe you can use the composite or any other method, you can restore that damage. But if it has exposed the pulp, but the crown is still a big portion of it is still available, then you can do RCT, root canal therapy, and then you build back the crown. Yeah, you can restore the crown. Maybe you do a jacket crown, or you can use a composite or whichever material. The second question is, what is the name of the dental X-ray that shows only one tooth? Okay, yeah, that is a periapical radiograph. Yeah, periapical. Then the other question from Abikaba is the pregnancy also a contradiction? Yes. Yes and no. If it is a complicated pregnancy, yes, of course, you will have to minimize. But if it's not really a complicated pregnancy, it shouldn't be any much different from a normal person. Yeah, but usually also when the mother is, let's say in the third trimester, the pregnancy is heavy, you know, them lying on their back is usually problematic. So you are better off delaying the procedures until they have delivered, because it's going to compromise their circulation, and you just see them going into into shock kind of, and yeah, so you don't want to do that. Yeah, like a syncope, they are very good at doing that, because the baby will rely on, you know, the blood vessels, the big blood vessels, and then you see the woman just going, Bob. Yeah. So yeah, so we avoid if it is possible, but if it's not possible, then you find the best mechanism of how to deal with that tooth. Yes. Good, wonderful questions. These are very good questions. Of course, yes, I know most people now fell off, others didn't come in this class. Oh, this is still one more question from John Wire, yes, that enlighten us on positions of surgeon during dental extraction. Yes, so the positions now, now I'm going to advise you can download a YouTube video which you can watch, but simply, if you are going to remove a lower molar on the right side, you're better off standing behind the patient. Lower molars on the right. Yeah. So because that is the best position, you can stabilize the jaw. Yeah. The ones on the left, usually we tend to stand a little bit more in front, because you see the hand is going to move from up down. So and the best, so it means you are pulling that tooth outwards. So when it's on left, so it means you are better off stand more in front. If it's upper, yes, upper left, you can stand in front, because you can again stabilize that tooth. The uppers, basically, you can do the uppers from in front. It is easier because it helps you to stabilize the teeth as you are removing them. So yeah, so that is what you do. But this is lower right, you have to, there's no way you are going to remove it if you stand in front. You must stand it behind. behind the patient. Then you stabilize the jaw very nicely and you can be able to remove. Yeah. So that said, yeah. Any other question? Any other question? I can see that now you guys have to go and read. And since there are no questions, okay, Paddy. Hello.
Yes, doctor. Yes,
Yeah,
doctor.
so I'm going to share with you the slides. Hello? Hello, Paddy?
Yes, doctor.
Yes, I'm going to share with you the slides. Then please you share the slides with all the class.
Yes, doctor.
Yeah?
Yes.
So, and you are about to expect mid-semester take home. Yes? Yes. So now you guys have to start revising. The moment you finish these papers, you have to start revising seriously for the mid-semester. Then after that, the end of semester exams. All right?
Yes, doctor. Yes,
yeah,
doctor.
I wish you people good luck. And so I'm going to share these slides with you right away.
Thank you, doctor.
Okay, welcome.